Well, good evening, everyone. It's 7:30 on Wednesday evening. Thank you for joining us. Can someone just throw in the chat if they can hear me? Can anyone hear me? Yeah, perfect. Thank you very much. Welcome along. So here we are. So Wednesday evening for tonight's free webinar. So good to see a lot of familiar faces back again and a good turnout again. So thanks for giving up your time. Welcome to STC Training Solutions. We are a pre-hospital care training provider based up in Aylesbury, providers of predominantly FREC 3 and FREC 4 courses along with the add-ons, and obviously working towards delivering our FREC 5 course hopefully early next year. So do keep an eye out for that coming. So welcome along. I'm Ines. I'm a paramedic practitioner by trade, and I do a lot of teaching with STC. Including on the courses and these webinars, which we've been putting together to help those of you predominantly that are going through your FREC 3 to FREC 4 transition. There's a lot of CPD and pre-course reading and a lot of understanding that's required to go from FREC 3 to FREC 4, particularly if you're new into the industry. So these webinars are really there to help those of you, and of course many of you are finding those of you with more experience that are out there working that these are useful CPD refreshers, which of course is brilliant. So as I say, thanks again for coming along, giving up your Wednesday evening. So we'll just give the last few people just arriving as normal. The numbers start to jump up a little bit at past. So those of you just arriving, not missed anything, to come in, get comfortable. And this evening we're going to be talking about patient assessment techniques. So it won't be a long webinar this evening, but we do have a quiz built in, which should be good. So we'll try and make it as interactive as possible. So jolly good. Numbers seem to be settling again, so that's fantastic. So as I say, we are a FREC training provider, so we do have some courses coming up. Those of you that have been signed in for a little while have been seeing the dates flashing up. We do have a few courses that are very nearly full now, so if those of you out there are looking at starting out, then do have a look at our FREC 3 courses coming up. They've been very, very popular recently. FREC 3 demand has gone through the roof, so there's not many spaces left before Christmas. So if you are interested in doing your FREC 3, do take a look. We had a cancellation on our 15th of November course, so if anyone's interested in that Monday to Friday course, there is one space left. Similarly, anyone looking for a SARM course, I know they've been really popular recently, and we've been sold out for quite some time. We have had a cancellation today. So there is a space on the SARM course on the 6th of November if anyone would like that one. And of course, ILS, we've got one coming up soon. And those of you that have done your FREC 3 looking to move on to something else, then obviously FREC 4 has the benefit of not expiring every 3 years, sorry. And for just $395, it's worth coming along and doing that next step up with a couple of courses coming up. One at the end of this month, over 3 weekends, if anyone's interested in doing that. Good, so it's just gone 7:30. It's time to get going then. So those of you that doesn't want to move on, they are having a problem. There we go. PowerPoint's being slow this evening. So those of you that are new to the series, well, welcome if this is your first time, but I can see lots of familiar faces. So we've already covered CPD requirements. As I mentioned last week, we're going to update that one because Qualsafe have updated the CPD requirements for both their FREC 3 and FREC 4 courses since we made that. So we are going to update that video at the end of this series, so in a few weeks' time. We've talked about some anatomy and physiology of the 6 systems that you need to know about for FREC 4, so do go back onto our YouTube channel or our website CPD section to have a look at those. We've talked about some pathophysiology involved in those systems, which is a good refresher if you've done this already, and good to have in the back of your mind as you go into your FREC 4. We talked about maternity care last week, which I think was really popular. We had some really good feedback from that. So thank you if you took time to feedback on that. It seemed to have been a very popular subject. This week we're going to talk about patient assessment. It's some very basic stuff really, but it's stuff that you need to know it needs to be comfortably in your head as you work through this process. Next week we're going to talk specifically about assessment of paediatrics because that's a very different subject. Following that, we're going to have a session on sepsis, what it is and how we manage it. We'll be talking about Entonox and oxygen guidelines coming up in a couple of weeks' time. Then we'll be talking through some ECG basics. That may be a couple of sessions that may not be able to fit into one. but that's ECGs for FREC 4s, basically. If you're looking at doing ECGs at a higher level, then do take a look back at our previous series, which was filmed about 18 months ago, which again, we'll be looking to update over the coming months with some new material. And then we're going to finish this series with intermediate life support, a theoretical run through. This doesn't remove the need to do a face-to-face ILS course every year if you've got a FREC 4 or FREC 5. But those of you that aren't having the chance to use it very much, then hopefully that'll be a useful refresher for you. So it'll be tonight is patient assessment. So we're going to be looking at the good old primary survey, the secondary survey. We're going to be looking at sample Socrates. We'll be looking at some normal adult observations, just making sure we're comfortable with those. And we'll be looking at a couple of assessment tools to help us with those. We want things to be interactive tonight. As I say, we've got a Mentimeter quiz going on again this evening, and there is a competition. So the winner of the quiz, so I want as many of you as possible to join in. The winner of the quiz will get 10% off any course of their choosing, but we do need you to sign up with your real name when you sign up to the quiz, so that we can actually put a name to who's won. So when you sign up to the quiz later on Mentimeter, it will be obvious how to do it. Put your real name in. The winner gets 10% off any course of their choosing. So feel free to put things in the chat. I'll do my best to answer any questions that come in as we go along. Obviously, as we get to natural breaks, I'll have a look through the comments. Feel free to tweet us, email us, text us, etc. if you've got any questions that come up. And that's, of course, after the event as well, if you think of something later. And get your smartphones ready for the Menti quiz as we go through. So recommended reading for this subject is the core text really for the FREC pathway. So that is Ambulance Care Essentials for FREC 3, Ambulance Care Practice for FREC 4, and good old JL Calc is the staple for everything ambulance related, isn't it? So due an update fairly soon, so I wouldn't advise buying the JL Calc printed guidelines at the moment. But we so I'd advise getting the app if you're looking at buying those. But certainly if you want to buy Ambulance Care Essentials or Ambulance Care Practice, we do have those available on our website with free delivery. So we're going to start the quiz now. Paul, you're jumping ahead. The code's coming. So go to menti.com on your smartphones. And then you're going to enter the code, which will be at the top of the screen there. As I say, if you're going to join in on the quiz later, I think it'll ask you your name later when you sign up. Just make sure you use your real name so that we can match you up, the winner up at the end. So menti.com, put the code in 19060957. I want you to answer the question first of all. What's the purpose of the primary survey? So you've got up to 3 answers. What is the purpose of the primary survey? Have a go now. Good. You can have up to 3 answers. There we go. Lovely. Well done, everyone. Great. To assess vitals, breathing, risk assess, quick assessment. That's it. That's the key there, isn't it? It's speed. Quick assessment. Establish time critical. I like that. Very good. Good. Lots of answers coming in. That's amazing. Dangle the prospect of a 10% discount on a course. Look how many people join in. It's brilliant. Well done, folks. No, really good answers coming through. Establish whether we're time critical to assess the patient quickly. I'm seeing lots of quick. Ensuring safety, to establish whether we're time critical. Absolutely. So treatment and diagnosis, I'm seeing a couple of times there, less so, as you'll see, less so. The primary survey is more about treatment. It's more about assessment than treatment. Where I would say treatment does come in is obviously basic catastrophic hemorrhage management and airway management. That type of stuff is obviously going to happen very quickly. But generally speaking, you're absolutely right. Everybody's on the right lines there of rapid assessments, deciding the kind of priorities of care. And to assess for danger, assess for life-threatening, time-critical injuries, which is really good. So fantastic. Let's head back to here then. So primary survey, absolutely, it's a rapid assessment. It's a stepwise approach. It is amended slightly for medical versus trauma, as we're going to see in just a second. The medical primary survey versus the trauma primary survey do vary very slightly. It allows you to form what we like to call a general impression. So you may hear the term out in the ambulance is big sick, little sick. it's a bit of a basic way of understanding things, but patients are either time critical or they're not, is what that phrase is saying. And the primary survey allows you to form that general impression of, is my patient time critical, or can I take my time here and maybe use alternative care pathways, et cetera, depending on where and who you're working with. Then we've also got this phrase end of bed assessment. So the primary survey is often conducted end of bed, if you like. So obviously not a patient that's in cardiac arrest, but a patient that's alert and recognises you as you walk in. We tend to kind of stand at the foot of the bed, metaphorically, and have a look at them and have a look at their general surroundings and how they generally present. And that's what the purpose of the primary survey is to allow you to make that first structured assessment of whether a patient needs my help right now to deliver a life-saving intervention, or whether we can wait a few minutes, gather a bit of history, and actually go in with a much more targeted intervention, rather than just, full speed ahead as we do in cardiac arrest. But rapid, stepwise being, we do one and then we move on. It's a very, very good method of doing it, and hence why it's been around forever and why it's not going to disappear. So this is the primary survey. I'm sure all of you are aware of that. So it's always been, Dr. ABC, wasn't it? But we add a few extra little bits in. So we add a D and an E. The two in blue are obviously the ones that differ slightly with trauma. So in traumatic situations where a patient's been injured, we would then consider these extra C's in blue. So that'd be the catastrophic hemorrhage and the possibility of C-spine injury. So let's work through that then. So danger, of course, above all else, danger is the most important thing. And that's not just to you, not just to the patient, but to the bystanders, to relatives, etc. So we've got to make sure that everybody on scene is as safe as possible. But of course, number one is you and your crewmate. There's no point you turning into a patient. Don't set out the rescue and end up being a patient. But absolutely, danger is always going to be above all else. The level of response, and we express that in AVPU, don't we? Those of you that have done courses will be aware of that. So A for alert, V for voice responsive, P for pain responsive, and U for unresponsive. As we go from A to U, we're of course losing our level of consciousness. Unresponsive being, they don't respond to shouting, they don't respond to shaking or tactical stimulation. Catastrophic hemorrhage, again, only considered in traumatic situations, but catastrophic hemorrhage is the type of bleeding that you're not going to miss. It's that kind of slip up in it, taste it, smell it, it's blood everywhere type stuff. So and by the very nature of where that appears, we're putting catastrophic hemorrhage above airway. So what I want you to think of is before you call something catastrophic hemorrhage, is it going to kill them before no airway will? Now, of course, no airway is going to kill you in about 3 minutes. So catastrophic hemorrhage, well, probably less. The catastrophic hemorrhage is going to have to be quicker than that. So real big arterial spurting bleeds that are uncontrolled. The types of bleeds you're just going to run up, put a tourniquet on, and then crack on with whatever else needs to be done. So that's what we mean by catastrophic hemorrhage, and it's going to be fairly obvious. You're not going to miss that externally anyway. Airway management, of course, comes next. Without an airway, there is no point trying to breathe, is there? So we're going to manage our airway using our stepwise management, which will be appropriate to your level of care. We've been talking about what we're going to do with our next series, actually, once this one comes to an end, which won't be too far off now. We're looking at doing some practical videos on airway management and other skills that people might forget how to do. So keep an eye out for those coming up. Whilst we're managing airway, we consider C-spine injury. Now that so airway still comes before C-spine injury in this case. So if we always get the situation of what if you're on your own, you've got a patient lying on their back and they're vomiting, you think they might have a C-spine injury and you don't have a suction unit. What do? Well, you roll them over and use some postural drainage to get rid of that vomit, because the airway is still going to kill them before a C-spine injury will. So the airway still takes priority, but if you have the ability to do so, protect the C-spine whilst you're managing the airway is the gold standard if you suspect any trauma, C-spine injury. And don't forget, particularly in the elderly, particularly in those with kind of underlying bone issues, we can have unstable C-spine fractures from falls from standing. So bear that in mind. We did talk a little bit about that on trauma pathophysiology. So if you have a look back a couple of episodes, we did talk around C-spine injury. Breathing, of course, once we've established it, we've got a clear pipe for the air to go in and out of. We do want the air to go in and out. So I remember being taught very early on in my career was air goes in and out, blood goes round and round, and any variation on that is a problem. And really that is the basics of how the body works, isn't it? Obviously, there's way more bolted onto it, but if you can keep air going in and out, you can keep blood going round and round. Actually, you're doing a massive service to that patient. So, keeping the breathing, looking at counting and assessing their breathing, taking their observations, which we're going to talk about later. And obviously breathing for them if the patient isn't breathing, and likewise circulation, measuring the observations, measuring the signs we have of good cardiac output, and supporting that with chest compressions if there isn't one. So disability and E, exposure, environment, everything else. These are the two that I think can confuse people a little bit. So if you look at A and B, airway and breathing are dealing predominantly with the respiratory system. We're looking at C, circulation, dealing with predominantly the cardiovascular system. D for disability is neurological disability. So it's looking at the central nervous system, looking at any kind of immediate threats to life coming from there. So things that we're going to consider with neurodisability are, of course, FAST tests, the face, arm, speech, and time, being for assessing for stroke. So stroke can, of course, be ischemic or hemorrhagic, but both should present with abnormal findings on the FAST test. The time, of course, for the general public being times called 999 if you recognise any of the one areas of weakness. Time for us as ambulances, no point us dialing 999. Is to consider whether we go to the hyperacute stroke units or whether we follow another local pathway. Not all hyperacute stroke units will take patients that have been more than 4.5 to 5 hours after stroke onset. So, but you'll get to know your local pathways for that. So otherwise, with disability, we're looking at pupil response, particularly in head injuries and suspected drug overdoses. As I say, looking at calculating a Glasgow Coma scale, which we're going to be doing in just a little while. And we're looking at things like blood glucose, and other causes of unconsciousness. So looking at different things that could have caused the patient to have a reduced level of response. That's what D is all about, looking at big brain problems that are going to kill them quickly. And then, of course, exposure is really planting the seed there for you to go into your secondary survey and really start looking in more detail. So expose, environment, examine, everything else. It's got loads of different synonyms, doesn't it? The E of the primary survey. But basically, in trauma, certainly it really is meaning expose. We are going to get down to skin nail and make sure we haven't missed anything. With environments or examine, we're going to be talking about with examination, we're going to be looking at reviews of systems, which we'll talk about later. So delving into a bit more detail about the symptoms that they have and when they started. Yes, absolutely. Exposure is the head to toe assessment. I'm going to show you a slide on that very shortly. Hope so. Absolutely. So part of your exposure, your examination, or everything else is a good top to toe survey, mostly in trauma. But if you think, metaphorically, we're kind of going to do that with the medical presentations as well. So your chest pains, your nauseas, your abdo pains, those types of things. We're going to kind of assess them top to toe as well, but not necessarily looking at them or exposing them fully. And then, of course, environment is to prompt you there to think about environmental exposure as well. So too hot, too cold, too wet, as I like to put it in when we teach this. So has the patient been exposed to extremes of temperature or been in water, nearly drowned, that type of thing. Things to think about as part of your primary survey that can just really help you nail down diagnosis nice and early and give them the best targeted treatment. So we're going back to Mentimeter. It's the same code again. So it's menti.com and then 1906 0957. The question now is going to ask you, what is meant by secondary survey? What do I mean by this term secondary survey? And again, you have up to 3 answers. So 41 of you on at the moment. So let's see at least 20 of you throw an answer up. You can have up to 3. What do we mean by secondary survey? Good. Good. Yep. Sample. Love it. Good. Ripper. Yeah. Second sweep. Yeah. More in-depth assessment. Observations. Good. Well done. Allergies. All systems. I like it. Excellent. Yeah, we're looking for life-threatening injuries that we've missed, absolutely. So sometimes your primary survey is going to miss things, but that top to toe that a lot of you are saying is absolutely what that's for. Really good. Second sweep. Good. Drug medical history, complete assessments, allergies, vital signs. Lovely. Really good answers. All systems, other unseen injuries, non-urgent considerations. I like that. It's a good way of putting it. Dr. Toe. Great. Perfect. So yeah, absolutely. A few of you putting sample there, which is good. So we're going to talk about sample very shortly. But what do I mean by secondary survey? So we are tailoring our secondary survey to the findings of a primary survey. So what do I mean by that? We are looking at what we found on our primary survey, and we're going to really hone in on anything that we think is abnormal. I'll give you an example. You go to a patient who looks to be a little bit breathless. You recognise that on your primary survey because you quickly count their rests and they're in the high 20s, for example. You're really going to hone your secondary survey, aren't you, onto the respiratory system. We're really going to start asking about, so have you had any coughs? Have you had any chest pain? When did this start? How did it start? I might do a bit of a Socrates. We'll come on to a bit of a Socrates about the breathing. And of course, you know, you're going to start with your history taking and with your sample assessment that we're going to go into in a minute. You might want to specifically know, do you have any known breathing problems? Really good question to ask when someone's breathless. Do they have past diagnoses of asthma or COPD or any of the other types of illness that exist out there? And of course, really useful nowadays, actually, a really good question to ask is, do you think you've had COVID in the last couple of years? Because actually a lot of patients still presenting with long COVID symptoms. I know at work at the moment, I see lots of patients with long COVID. So worth asking in this time. Patients that think they might have COVID, there might be some underlying scarring. So it's the whole point of the secondary survey is to allow for a better understanding of your patient presentation. What that means is starting to really narrow down your differential diagnoses and then, of course, actually your final diagnosis if you can get to it. The more experience, the more knowledge, the more training you have, the better you'll get at secondary surveys and being able to narrow down what's actually going on with the patient. You know, there's still plenty of patients I have sitting in front of me and I can't quite narrow down what's going on. But of course, we have a million, you know, other tests that we can order in primary care that we don't have access to on the road that really can help me narrow down a diagnosis. So don't be saddened, don't feel let down by yourself if you can't think of what's going on with the patients. Absolutely fine. Myself and many other paramedics will have gone into A&E many a time, I'm sure, and said they're unwell. I just don't know why. So it's absolutely fine to do. You have that gut instinct. You're allowed to have that gut instinct. But you can't put a finger on what's actually wrong. That's okay. That's okay. But the better you get at secondary survey, and the more structured your secondary survey and your review of systems is, the more likely you are to have that bingo moment of, oh, I know what's wrong with you. Okay. So we do require observations for a secondary survey, and of course, the further you got the chain, the more observations you can actually do and interpret. Obviously, when you start out with FREC 3, you're not trained to do all of the observations that are there. You only have a handful of those. As you come through FREC 4, FREC 5 and beyond, you'll obviously be able to interpret these observations a lot better. So we're looking at, as a minimum, really respiratory rates. Most patients get an oxygen saturation, don't they? End-tidal carbon dioxide, that's the partial pressure of carbon dioxide that's exhaled in the air that you breathe out. We measure that through capnography, which plugs into the life pack or the Zoll, whatever equipment you're using, and it gives you a trace on the screen. Really useful for patients that are suffering with severe breathing difficulties, because carbon dioxide changes a lot faster than the oxygen levels do. So a patient might have normal oxygen saturations, but actually have really quite high CO2. And that can just give you that early indicator that they're going into respiratory failure before the saturation starts to noticeably change. Yes, very useful in COPD, sleep apnea, very useful in asthma as well. Lewis, you can get shark finning, as it's called, a bit of a pattern that you'll get to know of the end-tidal carbon dioxide. And of course, where we use it most, I would say, is in cardiac arrest, particularly intra-arrest. Particularly if you're with a paramedic and they've intubated, we want to know that the tube is definitely in the lungs. We can do that by confirming the CO2 trace. We can also look for return of spontaneous circulation nice and early. So a sudden rise in CO2 during cardiac arrest can indicate ROSC, which is a good one. So we always have a very in-depth pulse check before the next round of CPR if we've got a sudden rise. And of course, post ROSC, there's loads and loads of evidence now that we should be getting patients back to kind of normocapnia, so between normal ranges, which we'll go into in a bit. As soon as possible after ROSC, and actually we reduce the incidence of brain damage and neurological deficit if we do that. So loads of evidence there. If you're ventilator trained, FREC 4s that come through us certainly are, FREC 5s certainly will be. If you're using ventilators post ROSC, it's stuff to know that you should be getting your CO2 down as quickly as you can and holding it within a normal range. Heart rate, of course, very, very useful, tells us loads of things, you know, rate, rhythm and character is the things you're looking for. So how fast, how slow, is it regular, is it irregular? How does it feel at the peripheries? And of course, with that, you can look at capillary refill time as well, which is always a useful measure, particularly in children, which we talk more about next week. Blood pressure, again, in adults is pretty useful, kids less so, but adults, our blood pressure tends to wean off relatively early when we're running into trouble. So, you know, a well-built adult should have a blood pressure, you know, 120/80 realistically. If we're starting to see, down kind of 90, we're 90 to 100, we're getting a little bit concerned. Although some, you know, very skinny people are going to be on the low side, and women tend to be on the lower side than men anyway. So not uncommon for young, slim females to be down in the 90 to 100 range as normal. But we'll talk about normal ranges of observations shortly. Glasgow Coma scale we're going to talk about. Temperature, of course, is useful for noticing signs of infection. But of course, some drugs can mask that. So paracetamol and ibuprofen are particularly good at masking fevers, particularly in the early stages. So patients that have had paracetamol in the last hour and they have a normal temperature doesn't necessarily mean they don't have an infection. Blood sugar, useful indicator for a few things. It's one of those things that we tend to do routinely for actually not particularly good reason. A patient that's unconscious, you definitely want to know that their blood sugar is normal. Patient presenting with a stroke, you definitely want to know that their blood sugar is normal, because stroke can be mimicked by hypoglycemia. Patient, any diabetic acting abnormally, clearly you're going to want to get their blood sugar. And there is some evidence or some stuff around with I know our first set of COVID guidance in the ambulance service focused in around hyperglycemia in acute infection. And also in MI, in heart attacks, you can see a little rise in blood glucose, but that's not particularly reliable. Obviously, there's other things that are going to point towards heart attack much more clearly, one of them being ECG there at the bottom of the slide. Peak flow in asthma, so measuring the peak expiratory flow rate, PEFR, it's often known as, measuring that before and after treatments of asthma. We did talk about that back on Pathophysiology a few weeks ago now, so do have a look at that one. Pupil response, as I said, in head injury and suspected drug overdoses. We have done some stuff around that on Trauma Day, but certainly one pupil larger than the other in the context of a head injury. So, fantastic. Yes, hello to anyone from ProMed who's here this evening. Looks like there's a few of you, so welcome along. ECGs, we're going to talk about, as I say, we're going to do a session or two on ECGs for FREC 4 in a few weeks, so come back to that one. And of course, some pre-hospital care decision-making tools, which we're going to talk about this evening, some just to help you out. So, back to the quiz. The computer catches up. There we go. So I've mentioned end-tidal carbon dioxide just for a little quiz moment there. Who can answer this correctly? So let's see if we can get half of you voting. What's the normal range for end-tidal carbon dioxide, the amount of carbon dioxide in the air that we breathe out in a healthy adult? Okay, healthy adult, nothing else going wrong. 4 to 8, 1.6 to 5, 4.6 to 6, or 60 to 100. What is the normal range for a healthy adult? Just give everyone a few minutes. Okie dokie, let's see where everyone's going. So 4 to 8, 1.6 to 5, 4.6 to 6. So I'm going to tell you that 33% of you are correct. So it is 4.6 to 6. Oops, being very slow tonight, isn't it? There we go. So well done to the third of you that voted correctly there. So normal adult range is 4.6 to 6 kilopascals. That's the unit of measure that we use on LifePak and Zol in the UK anyway. So with each breath, that's the partial pressure of end-tidal carbon dioxide that we'd expect to see in a normal healthy adult. And that's a number to remember. If you're ventilator trained, you should absolutely know those numbers. 4.6 to 6 is what you're aiming for. Once you get the patient on the ventilator post-ROSC, you want to try and get it to 4.6 to 6 using the ventilator frequency and then hold it there. So again, we are talking about doing some more practical stuff with our webinars for the next series. So ventilators will definitely occur in there too. Good, fantastic. Let's head back to the main bit. So well done to those of you that have remembered that. So normal adult parameters. So respiratory rates, we've got 12 to 20 for, this is all for our, as I say, healthy adults, 12 to 20 a minute, and end-tidal carbon dioxide, as you've just seen there, 4.6 to 6 kilopascals. Normal oxygen saturations, so over 94% in the healthy adult population. Excuse me, and just as a reminder, over 88% in COPD. Refer back to the pathophysiology sessions if you want to know more about COPD and why we treat them differently. But we tolerate an element of hypoxia in them before we start giving them oxygen. So 88 is the cutoff for COPD patients, otherwise 94. Normal pulse rate 60 to 100, but do use some clinical context there. Obviously, Mo Farah sitting in front of you with a heart rate of 90 is probably unwell versus little old Nana sitting in front of you with a resting pulse rate of kind of 59, 58 might be abnormal. Worth just using some clinical context there. So normal blood pressures. So obviously we have the two numbers, don't we? So systolic, we would expect to be technically between 90 and 140 can be considered normal, but again, you do need to use some clinical common sense there. So slim, late teen female, possibly could be down in that 90 to 100 and be normal. Me, if I was at 90, there's something wrong because I'm normally running about 130. So that's you've got to use a bit of clinical context there. The bigger you are, the more male you are. I don't know if that's a thing, but males and big males are obviously going to be higher. Smaller females going to be lower, but again, not always. It can be the sign of underlying problems going on as well. So just bear that in mind. Diastolic we're less interested in typically. Very low diastolics are associated with what we call postural drop or postural hypotension. So patients, particularly elderly patients, when they stand up, they feel lightheaded or faint. If they stand up too quickly, that's normally associated with low diastolics, but less than 90 is good. Over 90 or over 140 is considered hypertension or high blood pressure. Normal tympanic temperature. So depending where you read, unfortunately, there's a few different sets of guidance here, but 36.9 is your textbook normal body temperature. It does say plus or minus a degree. But if you look out there in the world at the moment, 37.8, you absolutely have COVID. It can't possibly be anything else. So of course, 37.8 in the book would technically be normal, but to the rest of the world is absolutely COVID. Of course, it's not. Anything over 37.5 is often referred to as a low-grade fever. Particularly in kids, you'll hear that term quite a lot. So 37.5 and up is a low-grade fever. As soon as we hit 38, it's known as pyrexia or feverish, having a temperature. Good. So 36.9 plus or minus a degree, but realistically, there's a little bit of debate over 37.5 to 37.9 whether that's truly normal. Blood sugars 4.0 to 8.0. Again, you'll see different terms written in different books. When I first got taught with the ambulance service, it was always 4 to 10. Since I've been working with diabetics in the community, it's absolutely much more kind of a narrower band than that, really. So ideally, we're looking for 4 to 8 in the healthy adult population. Don't forget, patients with diabetes, particularly as they get older, are going to have much wider ranges of normal, but generally nothing below 4. 4 is obviously anything too much less than that, you're going to start showing signs of hypoglycemia. Peak expiratory flow rate, you're going to need to refer to JLCalc, either the app or your pocketbook or the big textbook. There's an expected peak flow graph in there. It's towards the beginning of the pocketbook. I can't remember page numbers off the top of my head. I'm sure somebody can throw that into the chat if they've got it available to hand. But the JLCalc pocketbook does have a very handy graph, does the app. So if you just type in asthma into the app, you'll get up how to assess asthma, and it will have a little handy little graph. Just need the patient's age, male or female, and height, I believe it is, and that just gives you the expected range. The other place you can go to is MD Calc. I'm going to talk about them again a bit later. MDCALC. It's a website and an app. It's free to download, and it's got lots of ways of calculating things like that for medicine and expected peak flow. That's where we do ours when we do our asthma reviews and so on and so forth in primary care. We go to MD Calc for expected peak flow readings. And then of course pupil pen torches there. So when we're looking at pupils, we're expecting them to both be about 4 millimeters. You'll hear this term PEARL. Pupils equal and reactive to light. So both pupils are the same size, and when you shine the torch in, they both constrict by about the same amount. And at rest, they're about 4 millimeters. That is typical kind of normal adult. But of course, some people have very big pupils, some people have very small pupils, and do take into account whether they're looking up at the sun. With a lot of trauma patients, once you spinally immobilize them and they're staring at the sun, clearly you can't do pupil checks. So excellent. So back to the quiz. Let's go see what we have next. Which of the following is not included in News 2? We're going to talk about News 2 now. Those of you that have heard of it. Which of those is not included in News 2? Blood glucose, blood pressure, oxygen saturations, or temperature. If you're just joining us, menti.com 1906 0957, numbers at the top of your screen. Which of the following is not included in News 2? Glucose, blood pressure, oxygen, or temperature? Here everyone's going. Wow, don't need to teach you anything. Lovely, well done, everyone's got that right. Was that too easy? Clearly. Yankee Cokie. So here is news. So news, National Early Warning Score. This is version 2, hence News 2. They did have an older version which didn't include the two SpO2 scales that we're just about to talk about. So News 2, so we're looking at respiratory rate, fairly straightforward. What we're looking at is with each of these observations, we're looking at what the patient presents with. So let's give you a patient with a respiratory rate of 15, okay? So it's comfortably between 12 and 20, okay? So that's going to score 0. If the respiratory rate was 10, it would score 1. Similarly, if the respiratory rate was 23, it would score 2. If respiratory rate is 25 or over or 8 or under, then it scores 3, okay? And generally speaking, any one red immediately puts the patient at what we would consider medium risk, moderate risk, okay? So generally you need a little bit more than that to be blue lighting them to hospital. But at the same time, if you've got that in combination with a bit of a dodgy history and you know, suspecting sepsis, for example, they look unwell and they've got a single red score, then we could potentially be blue lighting them into A&E. Certainly, if they're scoring 7 or above, the pre-hospital sepsis guidance does suggest 5 or above. Some trusts went to 7 or above with COVID, didn't they? It's all just a bit up in the air at the moment. Technically, we're still working to 5 and above would be high risk for sepsis. So we look at the oxygen saturations has always caused confusion. You know, so it was initially taught incorrectly, I think, in quite a number of places. So scale 1. Scale 1 is for normal healthy adults traditionally. Okay. Scale 2 is for patients at risk of hypercapnic respiratory failure. So what does that mean? That means you're kind of card-carrying COPD patients that have reduced saturations on a normal day, okay? So if your patient normally runs at, 94 to 100%, or you don't know, you're going to use scale 1, okay? If your patient, it tells you they've got, severe COPD or other lung disease, and their normal resting saturations on a good day are less than 94. They're in that 88 to 92 bracket that we consider with COPD. Then we're going to use scale 2 because, as you can see, a patient is a patient with COPD sorry, a patient at risk of hypercapnic respiratory failure is going to be sitting in that low region anyway. So actually, if that's them on a good day, we don't want to raise their news score unnecessarily because it might just over triage them somewhat. So good question. So from Darren there, scale 2 is not COPD scale, it's for type 2 respiratory failure patients. Absolutely, exactly that. So it's, and when News 2 first came out, everybody was of the well, a lot of people were under the false belief that everybody with COPD was treated on scale 2. But let me tell you, COPD patients with COPD and low saturations are definitely in the rarer category. It's not most patients I deal with anyway with COPD have normal, you know, they're not going to be 98, 99%. All the time, but they do have 94, 95% normal saturations when they're well. So actually, if that patient is down at 90%, we probably should be doing something for them. You see that if I me as a relatively healthy adult, if you put me on the News 2 score and I had SATs of 90%, you would treat that as a score of 3. But if I told you I had COPD, you go, well, 88 to 92, that's normal for you. So not all COPD patients, just those who normally run low. They're at risk of respiratory failure. Okay. Hopefully that makes sense because it was all very misunderstood in the beginning when News 2 came out. So normal healthy adult or you don't know, use scale 1. COPD or other lung illness where they're at risk of hypercapnic respiratory failure because their SATs are normally low, then we use scale 2. Air or oxygen, if they need it. So if you get to them and they're on oxygen already, then you get a score of 2. If we give them oxygen, similarly, you get a score of 2. If you don't need to give them any oxygen, then they get a score of 0 there. Nice and simple. Blood pressure comes into it. A lot of people always pick up on so blood pressure of 219 systolic, as we know, is very much higher than the normal range. Why is that a score of 0? I can't give you an answer to that. It has been fed back to the people that made news or the team that oversee news. And I believe there is an update coming. I don't know if that's been confirmed yet, but there may well be an update to news coming, which will just segregate actually that blood pressure over 180 systolic should be seen same day, normally in ambulatory care. To have their blood pressure reduced because they're the massive stroke risk, obviously over 180. So somebody with blood pressure of 209 systolic is not going to be, you know, might score a news of 0 quite easily, but is not somebody that you would want to be leaving at home without any follow-up. But otherwise, it's mainly drops in blood pressure we're interested in with News 2. News 2, of course, was designed for sepsis. It was trying to identify sepsis, but of course, it's proven its worth and it's used now in a lot of different. Pretty much every patient gets a news score calculated, I dare say, now in the ambulance service. So, pulse, again, going slow or going fast is going to adjust your score. Your level of consciousness, basically anything other than alert, is going to score you a 3. So in the context of sepsis, predominantly, which is what this was designed in mind of, if you start to lose, your GCS drops below 15, you start to become confused or voice pain or unresponsive, then you would, that's a bit of a red flag. And temperature, again, you can get cold sepsis, hence why low temperatures also get you a high score. So cold sepsis is thought to be kind of multi-organ dysfunction where your thermal regulation just goes out the window and the body starts shutting down. You can get cold sepsis, but predominantly sepsis is a high temperature illness. And particularly adults, if you see adults with temperatures over 39, that's generally abnormal. Most adults can keep their temperature below that through most illnesses. So hopefully that makes sense as a bit of a recap for news or an introduction to news if this is the first time you're looking at it, something to go away and look at. Certainly from FREC 4 onwards, you're expected to use and understand news. So good. GCS, Glasgow Coma Scale. It is a useful way of expressing a patient's level of consciousness in a numerical form. It was designed for head injuries, and that's where it's most useful. Its number one limitation is, of course, intoxication. So alcohol or drugs can artificially reduce people's GCS. I reckon I could easily drink down to a GCS of 8, which of course is a medical coma. Anyone with a Glasgow Coma Scale or Glasgow Coma score of 8 or less is considered to be in a coma. And of course, you can look at those numbers and think absolutely alcohol can very readily do that to people. So we use, so it's 3 different scores added together. So if you've never used Glasgow Coma Scale before, we look at best eye response. The top 4 is basically AVPU, but given a number. So unresponsive 1, pain response 2, voice response 3, and normal normal kind of alert level scores you a 4, which is the best. Then we look at their verbal response, so orientated, so being able to have a conversation with you, knowing who you are, where you are. Level of confusion, we all understand probably what confusion means. Inappropriate words, I always kind of think dementia patients do very well. So you'll be having a conversation with someone, then it goes off on a completely different tangent, or in fact, random words start appearing in the conversation. That is kind of going from confusion to inappropriate words. Incomprehensible sounds, moaning and groaning, etc. And then of course no verbal response, being as it says on the tin. So that's 2 scores we've got already, and then we're going to look down then at the motor response, which is scored out of 6. So obeying commands, so asking someone to do something and they do it, is obviously going to get you a 6. Localizing and withdrawing pain is a subtle difference, and in the context of a head injury, quite important to pick up on. It's just as the brain power required to localize pain. If I put my hand on somebody's shoulder and they don't want it there, generally the response is for them to put their hand on my hand and pull it off. With that lower level, with withdrawal from pain, what they actually do is, if I put my hand on their shoulder, they don't want it there, they pull their shoulder away, and that's just a subtle difference, but requires less brain power to do the latter, to do the withdrawal from pain, and hence why it scores slightly less on the Glasgow Coma Scale. It indicates the brain isn't quite functioning as well as it would normally. Flexion and extension to pain, I'm going to show you on the next slide. In fact, I'll do it now. So flexion is the bending into the core, extension is the bending away. It's also known as decorticate and decerebrate posturing, as you can see on the slides there. So a good slide, this one. This is a very ominous sign. So in the context of a head injury, not something you want to see. It's a sign of brainstem herniation. It's a sign that the intracranial pressure within the skull has built up to such a state that, or such a pressure, that the brain is being pushed down through the foramen magnum, the hole in the bottom of the skull, and the brainstem is being compressed and causing abnormal flexion and extension. Unfortunately, there's very little coming back from that. So that's a very bad sign to see in someone on their GCS. So scoring 3 or 2 for motor is very ominous. And of course, 1 is no motor response. So you can see there that the highest score is 4, 5, and 6, which is 15, and the lowest score is 3. Now, when you're giving a GCS of anything other than 15 or 3, it is customary to give the breakdown. So we give it in eye, verbal, and motor in that order. So for example, 4, 4, 6 would be confusion, wouldn't it? So their eyes are open, they are confused, but they're following commands. 4, 3, 6, perhaps for dementia, with that inappropriate words tendency. The lowest score is 3, as I say. There's nothing there that shows a 0, so you've got to have a minimum of 3, which is just unconscious. There's some niches with Glasgow Coma Scale. You often say, what's the worst GCS you can have? Everyone immediately says 3. Actually, the worst GCS you can have is one of those that indicate brainstem herniation. So anything that scores a 2 or a 3 in motor response is going to give you is actually the worst GCS you can have. So a GCS of 3 is just unconscious. A lot of people out in the crowd tonight would have banged their head and knocked themselves out for a minute or 2. That's GCS 3 for a couple of minutes, and you're absolutely fine. I'd be surprised if there's many people out there that have been GCS 4, 5, or 6, made up of flexion or extension to pain and still functioning. It's a bit of an ominous thing. So, and as I say, big limitation is alcohol. When you've got somebody who's drunk with a head injury, is the head injury causing the low level of GCS, or is the alcohol causing the low level of GCS? There is no answer to that. You have to use clinical judgment and making sure that you're making the right decision. And you end up over triaging. The trauma centres are certainly used to having blue light ambulances arriving with drunk people in them with minor head injuries, just because they have lower GCSs. That's one of those things, but we won't labour the point. Top to toe survey, someone mentioned. Absolutely, here's a good example. I'm sorry, it's a little bit blurry on this for some reason. So the top to toe survey is focusing a lot around the head, but moving around the body in order of the parts that are going to kill you first. So obviously we're interested in chest injuries, abdominal injuries, lower limb, and then upper arm. So obviously spending a lot of time around the head because that's where all the important stuff is. Back of the head, looking for boggy masses would be described where you've got skull fractures. I remember being taught DOTS, so deformities, open wounds, tenderness, and swelling is what you should be feeling with as you go top to toe. That's stuck with me. I don't know why, but that's a very effective mnemonic for me anyway. So deformities, open wounds, tenderness, and swelling as you're going down your top to toe, focusing around the head, and then work down the body in the order of things that will kill you first. Okay. So samples are one of the most basic history taking methods you'll get given. If you've done FREC 3 or FREC 4, you'll have come across this. And basically, it's 6 areas that you want to know about all of your patients. Now, as you get good at taking history, you'll find that sample isn't very in depth. And you'll find other ways of taking histories. I'll show you the traditional medical model, which is kind of the one we all work up to. But sample is signs and symptoms. So what's wrong? Why are you there? Allergies. Whenever we deal with patients, we want to make sure we're not going to give them anything that they're allergic to. So medication and past medical history often go together. So with medication, we'll often prompt you into asking about past medical history, and likewise, if they offer up past medical history, you'll naturally be asking whether they take any medication for that. Last in and out is always the one people kind of scoff at a little bit and say, "What you're really going to ask when they last went for a wee and a poo?" Yes, actually, you kind of are. So I was taught fairly early on that actually, if patients are eating, drinking, weeing, pooing, and not vomiting, and they're doing all of that relatively normally, they're generally doing okay as a human. So if you look at the really nasty illnesses that we want to try and spot, a lot of them, the early stage presentations involve the bowel or the gut in some way. So either we're going to have vomiting, nausea, vomiting, we're going to have abdominal pain, we're going to have diarrhea, we're going to have urinary problems. There's lots of things that present very early on with gastric and genitourinary changes. And then, of course, events leading up to the problem is your history, is your chance to ask, well, what actually happened. In medicine, it can give you a little bit of a hint as to what the differential diagnoses may be. And in trauma, it can give you an idea of what the mechanism of injury is likely to be, i.e. what bits of the person are likely to be broken, and what type of treatment is likely to be needed. So sample is useful as a launch point as you get good at taking history, and then you'll find your own ways of doing it. Everyone does it slightly differently and has their own triggers for asking certain questions. I think if you're going to use sample, it doesn't particularly work that well in that order. So I find signs and symptoms, then events leading up to tends to be the next thing. Then I tend to ask past medical history, then medication. Whenever I mention medication, I always think to ask about allergies. And then I'm probably going to ask, how are you otherwise? Are you eating and drinking okay? Toilet's been okay today? No diarrhea, or constipation, urinary problems, etc. Good. So Socrates, really, really useful one on the flip side. So sample useful when you're brand new to it. Socrates is useful even now. I go to Socrates. I see that a lot of our GP trainees that come to our practice use Socrates. So site, where's the pain? Be specific. Sometimes that really helps you when the patient's specific. Onset. So how did it start? What were you doing when it started? Did it start suddenly? Did it come on gradually? That type of thing. That can really help differentiate. Angina and MI, for example, came on after I walked up the stairs and then went off again, or actually it just came on whilst I was sitting watching Corrie. Character, is it sharp, stabbing, crushing? Use an adjective to describe it. You'll get patients who'll do that fairly happily. Radiation, so radiating pain is use the chest pain example again. Chest pain in the center left of the chest, radiating up to the neck and the jaw and down through the arm is obviously a whole lot more ominous than pain that isn't radiating, but still you're going to take it seriously. Associated symptoms prompts you just to think about any other stuff going on, so dizziness, nausea, vomiting, abdominal pain, blackouts, that type of thing. Time pattern, I tend to think of as being how is it since it started? Has it come and gone? Has it got worse? Has it stayed the same? Has it got better? That type of thing. Has it been a constant pain there? Exacerbating or relieving factors can help you differentiate as well. So, taking a deep breath makes it worse versus, curling up into a ball makes my tummy pain better, that type of thing. And then the score. The score is important. So we take a score pre and post pain relief. So those of you who do FREC 3 with us and FREC 4 with anyone will get Entonox. Entonox is a very good pain relieving gas, but we should be doing pain scores before and after administration of that to make sure that it has actually helped. So Socrates is a good one to remember if you don't already. I still use that day to day. And this, I'm not going to labour the traditional medical model. These slides will be available to download if this is something you want to try and learn. But the traditional medical model is what we, as paramedics and doctors and other kind of health professionals, work towards with clerking our patients, so writing up notes about patients. And that's to identify the presenting complaints. You'll see these terms around a lot. So presenting complaint, why are we there? The history of presenting complaint is obviously what led up to it. Past medical history, exactly the same as sample. Past surgical history sometimes can be useful. Don't be that person that refers to the surgical SHO for query appendicitis and then actually turns out the patient had their appendix out already. It's very embarrassing, I've done it. So always ask surgical history, particularly around abdominal pains and things. Drug history and allergies, again, exactly the same way as sampled. And then social history, environmental history are quite useful things to consider. Social history, I tend to think of how does that patient live their life? So what do they do for work? Does that affect, if that's relevant, of course, to what's going on? What do they do for work? Do they drink? Do they smoke? Are they healthy? You know, how's their body mass index? All that type of stuff. And also think about the elderly, think about the vulnerable. Do they have support packages? Do they have family looking in on them? Do they have friends, neighbours, etc.? And that links into your environmental history, which again tends to be more of an adult, an older adult thing, and that's looking at their living environment. You know, they confined upstairs because they can't get up and down the stairs anymore. The only toilet in the house is upstairs, that type of thing. Are there loads of trip hazards and their mobility is not very good? How warm is it in the house, etc. And as Charlotte says, yeah, really important travel history. So getting a recent travel history in your social history can be quite important. That's certainly, we saw that at the beginning of COVID, didn't we? Looking at travel history about them. Review of systems, I'm going to talk about in a bit more detail tonight, but that's looking system by system at what's actually going on, to seeing if we can link any dots. And the more you learn, the better you get at that. On examination is your findings when you actually put your hands on the patient, did their observations, etc. Your impression is what you think is wrong. Your differential diagnoses are other things that it could be that we want to rule out, and we're not going to be able to rule those out in the ambulance service all the time. So that's why we go to A&E and refer into secondary care, etc. So that we can rule these things out. Your plan is what you document as being what are you going to do with that patient? That's just you. And then any recommendations, you'll hear SBAR, situation background assessment, and recommendations. SBAR is a way of handing over to other health professionals. So things that you might want them to do, you would pop in the plan. RX is any drugs given or prescribed. And then, of course, the really important thing, if you're not taking a patient with you, is to give some safety netting advice or a follow-up plan. So if things don't improve, or actually just make it clear to the patient what they need to do next if things get worse, etc. So something the ambulance service will drill into you if you guys end up working with them. So review of systems, as I said, is targeted questioning and focused examination. So it's looking at, let's give you an example of chest pain. Okay, probably we're going to look, our review of system is really going to focus around the respiratory system, because there's things in the chest from the respiratory system that can cause pain, and also for the cardiovascular system, because everybody thinks chest pain, thinks heart attack. So we're definitely going to look at the cardiovascular system. We're probably not going to look at the gastrointestinal tract in much detail, or the genitourinary system. We may look at the musculoskeletal system again, because muscles and bone in the chest that can cause chest pain. We're probably not going to look that much at the central nervous system, because there's nothing there that causes chest pain. Hopefully that makes sense. So you pick the most relevant systems. As when you're new to it, you tend to over review. And as you get more kind of honed in and you start to spot the signs that you need, you tend to narrow down your review of systems into the ones that really are likely to be causing things. But don't go too far. Don't get what we call confirmation bias, which is where you look at anything that confirms your diagnosis, but discount anything that actually tells you the real answer. So don't get funneled into that with experience. So some other scoring systems I'm just going to throw in there to help you with those of you that did the respiratory pathophysiology a few weeks ago. CRB 65, useful for patients that you think might have pneumonia. This is one of the good pre-hospital scoring techniques, tools. So new confusion, a respiratory rate of 30, systolic blood pressure below 90, or diastolic less than 60. and an age over 65, you get 1 point for each, and score of 4 is the maximum. It says 4 to 5 because actually it's the curb 65, but we can't measure the U part of it pre-hospitally, so we often just use the CRB 65. So the maximum score you can get from that is 4, and that determines how quickly you take them to hospital and to what extent the pneumonia is really set in. So, Wells score. So Wells scores are really good. They're too complex to put up on the slide. So I would say to you after this evening, folks, if it's something you want to look into, get the MD Calc app. That's their logo. You can do it online. You don't have to download the app. It's all free to view, and you can make an account and save your favourites, all free of charge. Look at the Wells scores for DVT, deep vein thrombosis, and pulmonary embolus, PE. Both very useful. They're used pre-hospitally a lot, so you should. Nobody's expecting you to remember them. I can't remember them. I always use MD Calc when I'm talking to a patient I think might have a DVT or a PE to get a score, and it's very useful actually. If you refer into secondary care, if you refer patients into A&E or to ambulatory care, etc., and you're saying, I think this patient might have a DVT or I think this patient might have a PE, they generally will ask for a Wells score. So it's worth calculating, and not difficult to do. This sort of stuff that anyone can do. So clinical frailty score is another one that you'll come across. So patient assessment, you know, a lot of elderly patients are frail, and that gets missed. And frailty is a diagnosis in itself. Being clinically frail, it unfortunately puts you at risk of lots of other complications of illnesses as we get old. So a lot of patients, so I don't know if it's still going on, but there was a trial with some of the West London hospitals that we were scoring anyone over 65, we were giving them a clinical frailty score when we handed over at A&E. The last couple of shifts I've done, I must admit, I'd completely forgotten about it, but I don't think it's still going on as a trial, but useful at the time because it did make you think, about, actually, is this the most appropriate thing to take them into hospital? And in the run up to COVID, we were using clinical frailty score a lot to determine whether or not we put people into A&E. Because of whether or not they were going to get ventilators, but of course that situation has settled, thankfully. So to end this evening, guys, so that's a whistle-stop tour of some of the tools available out there. Do have a look at MD Calc and JL Calc as well. JL Calc has some good scores in there. We're going to talk about the modified Tau-6 score for croup next week for children as well. So I'll give you some other ones that we can use. So we're going to end tonight with the quiz that everyone's been waiting for, the chance to win 10% off. It's formed off a case study, and then there's 5 questions. Okay, so your case study is a 56-year-old male that presents to you with dyspnea on exertion. So that's difficulty breathing when he exerts himself. Okay. His signs and symptoms are that he's tight-chested. He says he hasn't got chest pain though, but he has had a cough for 3 days. Okay. He is allergic to penicillin, which is worth handing over to hospital. He has medication prescribed to him, so he's on salbutamol and Spialto Respimat inhalers. Anyone that knows those inhalers will know that is going to signify either asthma or COPD. In this case, it is COPD. And he tells you that he gets really bad chest infections all the time. He's got recurrent chest infections. He had something to eat at lunchtime. He opened his bowels and had a wee an hour ago, and they were both normal, and he's not nauseous. His events leading up to today had a 3-day worsening cough. He's had shortness of breath on exertion, which is what SOBO means, which is a useful acronym. And he just feels unwell. He says he feels a bit rubbish, and he's glad that we're here. So in whatever context you're there, this is what you're going to find out. So you're going to do some observations. They are the observations. I suggest you write them down because we're going to go over to the quiz in a moment. If you don't have the observations, you might not be able to answer one of the questions. So his respiratory rate is 25. His saturation's in 90% on room air. Now, he tells you that his his saturations are normally okay. He's never been told that he has low sats before, okay? So he has COPD, but he's never been told your sats are low. Heart rate is 105 and regular. Blood pressure is 172 over 101. His blood glucose is 12.1. His temperature is 38.3. And his GCS is 15. He's normal. Okay. Oh, thanks, Matt. So Matt has put the observations in the chat. Yeah, BM of 12.1, temperature 38.3. Good, perfect. So the observations are in the chat. Hopefully you've written them down as well. We're going to go over to the quiz now. So as many of you as possible get involved in this. Let's get, there's 37 of you at the moment. So I'm going to go over to Menti. And it should, in theory, waiting for people to join. There we go. Right. Let's see as many of you can get in this. If you enter this, use your real name. And then we can link you at the end. If you win this quiz, it's 5 questions. If you win this quiz based on this case study, you'll get a 10% voucher to use on any of our courses, and that'll be valid for a year. So I'll just give a few minutes for anyone to get in. Go to menti.com, 1906-0957, put your real name in, and just enter the waiting room of the quiz. It is timed. You get 15 or 20 seconds to answer the questions. So you're going to have to think fast. Anyone else want to join? Once I start the quiz, you can't join. So if you want to get in now. Good. We are sitting at 20. Fine, over where we've gone over a few minutes. So I'm going to start the quiz now, folks. Okay, so get your phones ready. Answer fast to get the most points. Whoever scores the most points wins. What are we most concerned about with this patient? Exacerbation of COPD, sepsis, PE, or heart failure? All vote now. You've got 20 seconds. Okay, time's up. Okay, good. 10 people got that right. Well done. Sepsis is, of course, our concern in this case with observations like that. So let's see who's doing well. Well done. Okay, and the winner, Matthias, in the lead at the moment. Fantastic. Well done, Matthias. Okay. Next question. Oh, it's being very slow, isn't it? Okay, answer as fast as you can. What is his News 2 score? That's why I said write down the obs. 3, 5, 10, or 15? Okay, well done. 7 of you got that right. Fantastic. So his new score was 10. Excellent. Let's get the, it's got a bit of a lag on it here. See who did that. So, well done. Matthias again, on fire. Well done. Good man. Okie dokie. And all to play for though, Anthony right behind. Okie dokie. So, question 3. How much oxygen should we give this patient? This is a patient with COPD and suspected sepsis. How much oxygen should we give? And we're going by what JL Calc say. 100%, 40%, 4 litres nasal, or none. Well done. 9 of you got that right. JL Calc say 100%. Sepsis appears in the red box, doesn't it? Page 604 of JL Calc full text. I can tell I've told this a few times. 100% oxygen for everyone with sepsis, regardless of their COPD status. Fantastic. Let's see who got that then. Oh, Matthias slipped off there. So, fantastic. Anthony into the lead. Gary right behind. Well done, guys. Well done. Okie dokie. Question 4. True or false? It's best practice to wait on scene for a paramedic to give fluid. So this is in a patient with sepsis. True or false? Do we wait on scene for the paramedic to give fluid? Well done. It is, of course, false. So if you look at the Sepsis Trust guidance, they do emphasise that early transport to hospital, stating that query sepsis is the diagnosis, takes priority over the pre-hospital care bundle, which of course includes fluid. So if you don't have a paramedic with you, then you shouldn't be waiting for them. Just take them to hospital. The fluid, the evidence around the fluid is unlikely to make much difference. The only fluid you give is diesel. Fair enough, that's a good saying. A lot of people say that. Blue lights and off to A&E, get them sorted out there. That's where they need to be. So giving fluids is just one of the sepsis 6. If you're interested in reading about sepsis, we're going to talk about it in a couple of weeks anyway. So fantastic. So who did well on that one? Mateusz did well. Anthony did well. Well done. Perfect. Anthony still just out in the lead there. Well done, you. Okay. Last question then. Make it 1 to win. Which nebulized drug is often used in addition to salbutamol for infective exacerbation of COPD? Do we use adrenaline, dexamethasone, loratadine, or ipratropium bromide? Which nebulizer drug is often used in addition to salbutamol for infective exacerbation of COPD? Good, well done. That was an easy one, wasn't it? Fantastic. Who answered that the quickest? Let's see. So Natasha was fastest there. And that means Brian. Brian wins. Fantastic. Congratulations, Brian. Stole it at the last post there. So very well done. Brian, if you don't mind just popping your email address into the chat, or actually do a private chat to myself or Charlotte, STC Training Solutions. I'm sure you don't want everybody wanting your email address. So do a private email to us with your full name and your email address, and we'll get you that voucher sent out. And get you booked onto a course in the future. So well done, Brian. Very, very good. Stolen at the last hurdle. Very well done to Mateusz in second there. Matt Dinnery, well done. Anthony Ewart, well done. Some really good scores there, folks. So fantastic. Hopefully that was enjoyable. I think we've converted to using the quiz function in Menti. I quite enjoy it. So that is the end of today. So let me head back to here. We've done that. So we're done for tonight. Thank you for giving up your evening. Charlotte's going to pop in the links to a few things. One, so we do ask that if you've enjoyed tonight, you leave us a review. It really does help us get future customers in for the paid courses, and we really would like to keep these free. So if you have enjoyed tonight, then please do drop us a review. Facebook, Google, or Trustpilot would be absolutely amazing. In there, Charlotte has just put the link to Medal, which is where you can get your certificates. It does ask you for a couple of feedback questions. We see those, so it's always nice to hear what you'd like us to do differently. I hope you've enjoyed tonight. I hope it's been useful, and I hope it's been a refresher for those of you that have done this before, and hopefully it's made you a bit less nervous about starting it if you are about to go on a FREC 3 or a FREC 4 course. Of course, we would love to see you face to face. So if one of those courses does appeal, then do come and join us. I teach most weekends. So if you pick a weekend course, chances are you'll get lumbered with me. Or we've got the lovely Donna, who's just joined us, who teaches most of our weekday courses. So who's also a paramedic practitioner. So sport for choice. We'll be back on the free webinar next Wednesday. That's the 13th of October, 7:30 again. We'll be talking about paediatric assessments. Okay. Those of you going through FREC 4 will know that you need to know that in some depth. And of course, if you've got any questions, anything that comes up in the meantime, do drop us an email at webinars@stctrainingsolutions.co.uk. If you'd like us to do anything in particular with the next series, we're taking suggestions now. So do feel free to suggest future content. This recording will go up on our website in the next day or two, as will the slides and the link to the certificate. So if you do miss the certificate tonight, don't worry, you'll get it from Facebook or our website in a couple of days. They won't go anywhere, you'll still get a certificate. And as I say, leave us any feedback you want, and we hope to see you again next week. I hope it's been good for you. You're more than welcome, those of you saying thank you and goodbye. Have a great week, and I'm glad you've enjoyed it. And I'll take questions now on the chats. Drive safe, Matt. Still got a little while to go. I'll take questions on anything from tonight or anything in general, anything about courses, anything about anything, meaning of life. Things I don't have the answer to is where to get diesel in West London. But apart from that, I should be able to help you. I'm going to pause the recording there so I don't have to edit it for hours later.